Thank you, my friend, Professor Mezba, and all my friends here. First of all, I would like to thank the organizing committee to give me this opportunity to talk to you. As you know that IDF faces a lot of challenges. It's not IDF, it's actually the people with diabetes. And all those people who are serving this community is facing a large number of problems. I'm going to raise some of those issues that is needed for the people with diabetes. And that I start with the global access to insulin and the International Diabetes Federation, what the International Diabetes Federation is doing. It's my honor that I could talk to you and share my thoughts with my colleagues in the region. And I think that this is one of the priority that will be given during my tenure as president of the IDF to secure the global access of insulin to all people who needs it. So therefore, I would like to focus on this issue. If you see the history of insulin, that I see that there are many discussions on this, that the insulin was discovered in 1921, which is not correct. So actually from 1869, that we know that Langerhans, actually he discovered that a distinct collection of cells within the pancreas, later that's called the Langerhans, was actually, so this was identified, the secretion of insulin and where it is actually located in 1869. In 1902, that Eugene Opey discovered that islets of insulin produces insulin and that the destruction of these cells result in diabetes. So cause of diabetes was already established in 1901. 1916, the Romanian professor Nicolae Paulsen developed an extract of the pancreas and shows that it lowers blood sugar in diabetic dogs. So they did an experiment in dogs already in 1916. And then comes 1921, when Dr. Frederick Banting and a medical student Charles Best performed the experiments on the pancreas in dogs in Toronto. So this was that was done in 2016, in 1921, which was a success. And following the success, a 14-year-old boy with type 1 diabetes called Leonard Thompson is given the first medical administration of insulin and survived for another 13 years in 1922. So what we did the uniqueness of 1921 is that we have successfully applied insulin in order to treat the human, not the insulin was first discovered in 1921. Banting, the MacLeod were awarded the Nobel Prize in Physiology of Medicine, and MacLeod, however, failed Best and Collip were equally eligible and shared their prize of money. So in 1923, they received the Nobel Prize. And we all know that a new race of diabetes has come up on the scene. We saw Jocelyn in 1922. With the modern discoveries, particularly insulin, have completely changed the outlook. There is no reason why a diabetic should not, if he can, be taught to do so, lead a long, normal life. Have we done it? A question to you all, we should all look back what is this, still in 1922, what are the challenges in the life of the changes that we have seen in change of Leonard Thompson, could we secure to all people with diabetes today after 100 years? This patent for insulin on January 23rd and 1923, the Banting and Collip were awarded the American patents for insulin. They sold the patent to the University of Toronto for $1 each. Banting notably said, insulin does not belong to me, it belongs to the world. Its desire was for everyone who needed access to have it. So this was the encouragement, this was the motto. The impact of miracle insulin, because as you can see that in the beginning, it said that type 1 was a death sentence. That we have seen that how the life expectancy has changed over the years. Then comes the insulin industry. The NPH is an intermediate acting insulin, as we all know, is marked by Danish pharmaceutical company Novo Nordisk in 1950. In 1955, The insulin is sequenced by British biochemist Frederick Sanger, and he got a Nobel Prize actually for this work. And in 1963, insulin became the first human protein to be chemically synthesized. So with a little bit of the history, that we 78 in biotechnology from Genentech used the recombinant DNA technique. In 1982, synthetic insulin is renamed as human insulin. And in 1985, Novo Nordisk introduced the insulin pen. 1992, Medtronic releases the Minimed. And in 1996, Eli Lilly marked the analogs of insulin. And in 2000, more than 400 patients with type 1 diabetes received the islet cell transplantation, which is still not being fully successful. So you see that this is a little bit of the interventions, and we should be thankful to the industry that they have actually persuaded in order to develop the technologies in order to give this treatment to the people in the best possible way. Now, how is the world looks today? You see that there are three companies, Novo Nordisk, Sanofi, Eli Lilly. It is the three main actors who are dominating, if you look on the side of insulin volume and the market share of the world, and the insulin volume market share worldwide. If you look at these two, this is the data actually from 2006 to 2011. I have checked it recently. It has not changed. Particularly, it is still more or less remains the same proportion. So what we see that these are three major companies who often sponsor all our activities, and they have made the most modern innovations in order to deliver the insulin to human. Then I'm talking about what is happening, recognizing that insulin is an essential medicine, but concerned that despite of being discovered 100 years ago, not correct, as I said, in 1921, globally about half of the people in need of insulin have no longer or irregular access with unacceptable inequalities between and within countries. Only 50% of the people have access to insulin. But if you look at the sub-Saharan Africa, the number was found to be only 1 in 7 people. This is the situation in sub-Saharan Africa. That we said that as I have said in the first slide, that now the modern discoveries, particularly insulin, have completely changed the outlook. There is no reason why a diabetic person should not, if he can be taught to do so, lead a long and normal life. And we are far from it. So I always remind that when we celebrate anything, we should think about what we are celebrating, why we are failing, why we are not able to deliver the life-saving drug to all the people, despite of all our collaborations. And I'm saying that it is not only the responsibility of the industries, but we have a joint responsibility, the government, the industries, and the civil society. There is a joint responsibility of all those. It's not only the industries. The gaps and desired outcomes in the number needs in diabetes. You see that what we have achieved in all these years, I'm talking about, that of the estimated 415 million is the old data, is because now we are talking about 570 million people with diabetes, that we have about 10 million diabetic population, and about 50% are diagnosed. That means 50% we are failing to diagnose. And of whom about 50% receive care. That means we are talking about losing another 2.5 million. And of whom 50% achieve the treatment targets. That means we are coming down to 125. And of whom 50% achieve the desired outcomes. So this is our achievement with all our medical discoveries, and which will result in, we have been successful in 6% as medical doctors, scientists, we are here. We are successful in 6%. We are failing in 94%. Why we are doing so? What is the reason that we are not doing any better? If you look at these places, that I would say that the reason that we are not able to diagnose more than 50% of the people is because of the policy failure. About of whom 50% receive care, it is the healthcare service failure. And the last two part is actually treatment failure. that comes directly on us who are here. So we need to think that, of course, it's not the total responsibility of the doctors. There are policy failures, that healthcare is organized by the general government, but the two last part is the treatment failures. If you see the cost of production of government procurement and public and private sector patients, prices to human analog insulin based on 43 countries. This was actually data published in 2021. It's a recent one, it's no old data. So you can see that on your left-hand side, you can see that cost of production, and you see the government procurement, the patient procurement, and if you see the analogs, that cost of production to patient price in private sector is on the extreme right. You can see the amount that the people are paying. There is no control in many countries. There is no control, particularly the United States of America, because they believe in free market. Free market doesn't mean that we do not have any ethical responsibilities. And this is the availability of insulin in public and private sector in sub-Saharan African countries. So you see that the dire situation in sub-Saharan Africa that I said that in the beginning, that only 1 in 7 people of those who need the insulin have access to insulin. If you see this medical reimbursement trends for covered insulin production from 1901 to 2014, if you see that, for example, the rapid acting insulin, you see this on the top, and then long acting insulin, and then premixed, short acting, and intermediate. You see that how the prices have actually increased over the years. In President Biden in December 2021, he said that imagine what it is like to look at your child who needs insulin and have no idea how you are going to pay for it. Biden said, let's cap the cost of insulin at $1.35 a month so everyone can afford it. We are not talking about the poor countries. We are talking about the policy failure of a rich country. And that is the situation. We in this hall, we should see that we have been blessed by God or Allah, whatever you believe in, that we are not in that situation. But we should not forget that many people have to make a choice whether to buy food for the rest of the children or to buy insulin for one child. as you know that I come from a poor country. I come from Bangladesh. Even though I lived most of my life in Norway, a rich country, I've worked in Africa, in particular in Tanzania and Zimbabwe. And I also have a guest professorship in Brazil. People say that I live in 3 continents. One is in Bangladesh, where I come, and I actually still am a guest professor in Bangladesh. I live in Norway. My wife comes from Brazil, and I also have a guest professorship in Brazil. I've seen, Allah has blessed me to see the world and the challenges. And if we see this as blessed person on this earth, with our knowledge in science and medical science, we do nothing, we will not be forgiven. This is again a short description of the central medical store, the public sector, the private sector, the patient and patient care services. This is again the kind of graph. If you see on your left-hand side, you'll see the affordability of days' wages. That means how many days' wage you need to spend for a vial of insulin. That gives us something to think in different countries. Of course, you see that there are different countries and but it seems that if people pay several days' salary to buy one insulin. I have met one patient in Africa that that man was relieved because his child, who was type 1, died. Now he can buy food for the rest of the family. This is the situation that the parents, we all are parents, most of us, we should think we also have our children, and if we have to make such a decision, how terrible it feels. This is again one index on affordability and availability in the public and private sector. I do not want to go into. We have said that what are the challenges that we have seen, that challenges in these are the three different countries, Mozambique, Zambia, access to different pricing, different prices between government tender prices and the prices to the facilities, insulin purchase locally more expensive, that it also differs. You see that Mozambique and Zambia. And Maputo province equals to about 11.3% of the total population, receives 77% of the total amount of insulin in Mozambique. A snapshot survey carried out by Health Action, they found a significant differences in average prices in Europe and Southeast Asia. Across the WHO regions, the average prices of insulin from one company doubles from US $15 per vial in Southeast Asia is 32 32 in Europe and 15 in East. It's the same company who produces this insulin, right? And we have seen this cost of production, why it varies from country to country, because of the negotiating ability of that countries. So you see that it's not that, therefore I say that, as you said, that I have mentioned, that we forget to acknowledge the sponsorship that we receive. Actually, it comes from the people with diabetes. What are the barriers? So if I try to look at that, what is, you see that, for example, if you start from medicine and there's the central depot, and then these are the two countries, the distributor comes, and then distribution to other costs, distribution, and the wholesalers, the private pharmacies and public hospitals, patients with health insurance, patients without health insurance, and the total price that at the outpatient facilities that the patient has to pay. So there are many layers that we have created, and every layer is being benefited at the cost of the money that the patient will have to pay at the end. This is also one of the diagram that how this mechanism works. Human cost decreased life expectancy. If you see this life expectancy of today with type 1 patient, if you say in Mali, 1, Mozambique, 3.5, Vietnam, 7.2, Zambia, 11.2, Nicaragua, 22. Do you think it's acceptable? We are witnessing the death, not only the death, because it's not a natural death, it is a specific death due to our policies. That means we all are responsible for this happening. And then it comes a new challenge, that is that the modern insulin that is coming in, that you see the transition from human to analog insulin. You see that if you still look on this, high income countries, upper middle income countries, lower middle income countries, and low income countries. If you see this, for example, the gaps, that for example, this between the red is the human and the blue is the analog. You see that in the rich countries, you see that it is now the analogs are taking over. The upper middle class, it's still gapping, it's narrowing, but it still is there. Lower middle income countries, the gap is far less. And in the poor countries and the low income countries, actually, we see that the human insulin is still the most prevalent one. Why it is so? It is simply because of the cost. The analog costs much more. So IDF Access Initiative now is question of what IDF is doing. Then adopted the WHO Executive Board in January 2021. We, from the IDF, took an initiative in 2021 to take a WHO resolution on universal access to insulin. I've worked, but it was blocked by the rich countries. I do not want to go by names. These are the countries who produces the most insulin. Why? So we could not get it passed in 1921 because of this blockade. And then at the end, so we got one WHO decision on the World Health Assembly that IDF asked the member association to help mobilize national governments to support the decision on December 2021. However, we managed to get one resolution on reducing the burden of NCDs through a strengthening prevention and control of diabetes, which is a kind of negotiated result because we want a price transparency. The countries, they didn't want a price transparency with the focus that is because of the free market policies. We also, I do not want to get into more politics. We also know that why, for example, Singapore, not Singapore, that became the British colony for 200 years because of free trade. So we do not want to discuss about these free trade policies, but what we say that it is an unacceptable situation. IDF Access Initiatives number 2, the Global Diabetes Compact. You will be happy to know that it's the first time that we were able to create one diabetes compact in the WHO. IDF is the key WHO partner for the implementation of the compact, and regular calls are being held with the WHO and the NCD team. Over 30 participants from the IDF network participated in the informal consultation with the people living with diabetes in March 2021. IDF was involved in the compact launched in April 2021 and in the stakeholder consultation in October 2021. IDF and several its regional members have participated in all compact forum meetings so far. WHO diabetes coverage targets adopted at the WHO World Health Assembly in 2021. That is the modified resolution that was passed in May 2022. In September 2021, IDF participated in a consultation with civil society and asked that to 80% of the targets for diagnosis be modified to 100% of diagnosis for living with type 1 diabetes. IDF is asking its members in December 2021 and April 2022 for help to mobilize national governments to support the adoption of the targets. You see that IDF is working, but we cannot work without your support because the WHO doesn't listen to IDF, but WHO listens to the governments because our governments are the members of the WHO. So therefore, in order to influence any WHO's policies or UN policies, you need to engage your national governments. So in my thinking, I do not know that, in my thinking that we need to, IDF should be working closer to the governments because as the way I see it, that the people with diabetes, the number of diabetes increasing is a national problem. But for the industry, it is a different story. So we need to work with the national governments. IDF Access Initiative. So special issues for centenary of insulin that we published in DRCP, a special issue which I edited, and a special insulin at 100 sessions during the World Diabetes Congress that was virtual in 2021. In April 2021, the joint webinar on NCD forum promises the action supporting the implementation of the WHO Global Diabetes Compact. In November 12-21, joint webinar on PAO, increasing the access to diabetes care and the region of the Americas. So IDF is doing, so IDF Access is also access to care of humanitarian, and WHO Essential Medical List now is also including the SGL2 that we have included, that's SGL2 in the diabetes and the community engagement. IDF School Access also takes to the IDF School and also the UN high-level meetings for universal health coverage. Challenges with insulin is high cost that we have said, limited producers, because as you said that the 3 countries are dominating more than 90% of the total global market. Heat stability and cold chain. Data from a study carried out in UNICE and MSF, transition to analogs is a big problem, as you have said, that there's a big gap between the rich countries and the poor countries. Biological versus chemical entity, the regular issues on biosimilar versus generics. Not only an issue of poor resource settings. In the US, insulin discontinuation was the leading precipitating cause for the decay in 68% of people in US inner city settings. 27% reported lack of money to buy insulin. That's the US story. Greece during the financial crisis, we all know this financial crisis that went. So these are the challenges that we say that in Lancet, that what says that what is the commonest cause of death in a child with diabetes? The answer from a global perspective is lack of access to insulin. Join hands to secure accessibility of insulin to all those who needs it. IDF cannot do it without your support. It is not responsibility of one. It is the common responsibility. It is not only responsibility, it is your human dignity. If you think of your own child, and it is, we cannot escape the responsibility that for the deaths that is occurring in front of our eyes, we are not responsible for it. Thank you for your attention.